Hey,
Yeah.
Charles.
Hey, Mel.
We're live, Charles.
Yes, we are. Hello, everybody. It is August 1st, and it's a Saturday. And I want to welcome you all tonight to Mel and Charlie Live here on Facebook with our special guest for the second time, Dr. Darragh O'Carroll, noted physician and pretty much an expert on pandemics. He's been in a few himself, and he's a frontline emergency room physician over in Honolulu. And I understand from our last interview with Dr. Miskovich, he's joined the Miskovich team. So that's exciting. But we'd like to say aloha to all of you. Hope you're having a great Saturday. Today has been a beautiful Saturday here in Kauai. So wherever you're at, I hope you're experiencing the same weather. And if not, then I'm pretty sure that day will come when the weather will get much better. But for the most part, it was sunny. It was sunny. It was a little bit on a humid side, warm side. Other than that, how's your day, Mel?
Hey, I got certified today.
Nah, right on.
Yeah, now I can do this.
Anyway,
Share, if you guys can, please click the share button. Charlie's chair is wider now.
yes, yes,
It's
yes.
really cool, man. Now I think a lot of people are gonna realize that it was never a chair. It was
No,
never a chair.
it's actually you can pick this up at the fair. You know when they control pies at you, and yeah, you stand behind that screen. This is one of those screens. Okay, gang,
Ah,
go for it. Go for it.
wow, Linda is watching from the bullshit.
Huh?
Jeez, Linda Kawai Iwamoto is watching us from the bullshit restaurant.
Wow.
She's,
Thank you.
I can see her right now with her date
Yes.
sitting on the table,
Yes.
turning on the phone and telling everybody to be quiet because Mel and Charlie is on. Oh my goodness. Thank you, Linda. Thank you very
Thank
much.
you. Hey, why
Like
don't
you
you
said,
do your
you're
certification?
sharing earphones. Huh?
Your certification. Get it up there. Show your
Oh
certification.
man, I tell you, I was so proud and happy when I got that. Now I can actually use this high-tech uh, sign system.
Yep.
So you got to really go ahead and hit the share button, do a share watch party, whatever you can do. Tonight's information is going to be, I think, very interesting. You know, from when that's the beauty of this program is that we bring people back. This is Darrah's Dr. O'Carroll's second time he'll be back, but so much has changed. So much has changed since the last time he was on, and I think we all agree that he was very informative. You know, this guy was part of the Netflix consultation crew for a series or a show that Netflix produced. I mean, the credentials are there. Charlie, you have a glare on your sign. The sunlight. Oh, mine on this. Oh, maybe. Okay, here.
Hmm.
There we go. Anyway, it says share. Yeah, applause. So just hit the share button, start a watch party, do whatever you got to do, get this thing up. I mean, last night we had, I don't know, probably 4,000 viewers last night.
Yeah.
Um, you know, our appreciate you guys joining us every night. You know, it's really again just to feed you guys some information and for us as well. You know, we're learning every single day. And you know, I do have some questions for the doctor because I did run across a couple of people that experienced COVID firsthand in their families right here on Kauai. And so I have some questions as far as incubation because I think the more and more cases that we see and we examine, you know, we learn more of this virus. And I think the more we learn, you know, we only can get better. So I know a lot of people are concerned about the shutdowns and the quarantines and the economic death that we are experiencing. A lot of businesses are slowing down, but I think you know we got to really understand that um, this virus is not slowing down right now, and we had a little drop in the numbers today. It's the weekend, and we'll see where it goes for the rest of the week. I'm hoping that we'll be on a not a climb, downward slope,
Downward
uh,
spiral.
back to where we were
Yes,
just
hopefully.
a couple of weeks ago, because I think that that just makes people feel a lot more comfortable. But Dr. O'Carroll will cover what's going on. He's been active on Oahu. Again, frontline doctors, that's who we want to bring on and share what's really going on, not what someone Googles and finds stories and posts all these different stories, or using social media as their main source of data. I think when we get the doctors on, I think it's very important that we pay attention to what's going on, especially doctors that are working frontline in the areas that we're seeing some heavy activity with COVID. So
Mhm.
Keith is all the way in Southern California. I don't know if you know where Zuma Bay is, but someone just posted a picture of Zuma Bay in California, and it was a mess. It was zero social distancing. I don't know how many people were on that beach. It was a ton. Um, I'm getting complaints during the day. I just had one. Garage gatherings. The mayor, we all know now, the mayor reduced the gathering number outdoors to 10. And I'm getting the complaints. And I'm gonna be honest with you guys. I'm sending them over to KPD. I am sending them over to KPD. So if it says you guys, I apologize up front, but um, we all gotta take that proactive action. I mean, really, we should all know better. We should all know better than to go and participate. Eric is asking, who do they complain to? You complain to KPD, Kauai Police, 241-1711. There's also an online complaint form that you can use, and that you can be anonymous. And I've used it before. It's very responsive, so you can do it as well. Go to kauai.gov/COVID-19, www.kauai.gov/COVID-19, and right on the top of the page, you'll see a red button that says online complaint, I think it's called. And you can report all your violations that make sure they're violations. Don't use this as a tool for make trouble for a neighbor you don't like. Really, if it's a problem like the one I just reported, over 20 people, no masks, no social distancing, and people are still coming. So it's going to be a big party tonight. And again, we had a lengthy discussion with our mayor last night of why it's important that we follow the rules. And I think after tonight's discussion with the doctor, we'll understand this virus is so easily transferable. And many of you may think that, we don't have the virus here. Well, we do. We do have the virus, and we don't want to spread it. So anyway.
Well, I'm hoping to find out from the doc, a lot of these cases, by the time we find out, or by the time it's analyzed at the labs and reported as an infection, what period has passed going into the shedding process, right? I would like to know that. I would really like to know that, because what we're now seeing is when it can become the most powerful, when you're gonna transfer the virus to others. Before, you had to, there's many different theories, but we know that enclosed areas with poor circulation is one of the hotspots. One of the hotspots. Well, I heard a ding ding. Is that our
Yeah.
guest for tonight?
Yeah. The ding ding is our doorbell. That's our doorbell, and that means Dr. O'Carroll is in the waiting room. So we're gonna bring him in a little bit early tonight, so we can get started with the dialogue
Yes.
and have some. If you got some questions, go ahead and shoot them over. Post it in the chat box. There's Dr. O'Carroll connecting to
Hey, Doc.
audio.
Oh, hold on. I didn't even connect my earphones. Hold on one sec.
Oh yeah, we can hear you perfectly fine.
Oh, there we are. How are you guys?
Fine. How are
What's
you
up,
doing?
Doc?
Yeah, how you doing?
Are we live? Are we live?
Yes.
We are live. We are
We're
live.
live. Oh, okay. All right. Okay.
Hi, you welcome back, my friend, Dr. Darragh O'Carroll. I understand you may have changed your. Are you with Dr. Miskovich now?
We're in discussion with some things. I don't know. We're seeing if it's possible. Not sure yet though.
Okay, but you are. Oh, so you're with Kuakini. You're still with Kuakini.
Kuakini. Yeah. Yeah.
Okay, awesome.
Yeah.
Well, you know Charlie and you know Mel. So why don't we remind the people who you are a little bit, and then let's just get right into the discussion, man. Let's go have some
Sure.
updates.
Oh, updates from me. Oh, okay.
Yeah, man.
I thought you guys were gonna go right on to it. Okay. Yeah. I guess in general, this virus is doing what we expect it to do, which is spread. It's really good at that. It's twice to possibly 2.5 times as transmissible as a seasonal flu, and seasonal flu rips around the globe every year. And most estimates of its, this isn't the only number that you need to look at, but mortality rate is about probably going to end up around 0.5% or 0.6%, which is 4 to 5 times as high as seasonal flu. So when you combined how infectious it is, plus how the mortality rate, and not just the mortality rate, but how many people actually need to be in the hospital. And when they are in the hospital, they're in the hospital for a long time, sometimes 8 to 10 weeks if they have to go onto a ventilator. So it's a really, really, really serious illness that, I think Hawaii in general we were really, really good at the beginning of when this came out, and really good at doing our part, everybody doing their part to wear a mask, socially, physically distance, and wash their hands and take care of what we needed to take care of. And I think it's only human nature, and it needs to be combated by repetition, is that we got to keep doing it. We got to keep doing it. I was driving around east side of Oahu today, and there's a lot of people out at the beach, and there's a lot of people very close together, and a lot of people, probably nobody wearing a mask, which albeit eating food and sharing utensils. And it's gotta, I don't want to chastise, but look, the more that we do that, the more that we're going to, not saying that you can't hang out in your Ohana group, but you got to keep those just into your families, and you got to keep those groups less than 10, and you can't mix households, because that's how this virus is going to spread, household to household. And that's where it spreads the easiest, is indoors. And so I'm very in favor of the Department of Health and Mayor Kirk Caldwell, who shut down, at least temporarily, the bars, because we needed to put some brakes on this. We've had cases kind of skyrocketing from 70 to 100, 120, and now, back down to 87, but it's the 7-day average. And probably what's better to look at is not the total number, but the percent of positives, but probably a better outlook is the percent of cases that can't be tied to a known cluster or can't be tied to a previous case. So what that means is that it's kind of spread into the community, and we don't know where it is. And so we're nearing positive cases as high as, in our testing batches, is 5-6%, where just a couple of weeks ago we were down in the 1%. So this is a time for all of us to reevaluate our actions, and if we want the health of our communities to remain unlike what happened in New York, Texas, Florida, California now, we all need to be serious about it.
Well, I think, you hit a very important topic. We talked about it last night, is the individual responsibility. I know we were talking in the last few nights about the percent of positives at 5.8 or 6%, which is extremely high, I think, based on the trends that I see in other places. That's quite high. But you bring up another concerning point, is the percentage of positives that we cannot track, that we cannot find a source. So, if it all came from a bar, then okay, that's while it's not good, at least we know. But what's the percentage, if you even know? I don't know this, but what's the percentage of cases or positives that we don't know, that is not connected to a household or a facility or a gym or a bar or whatever? What's that number? Because we can't
That number
get it
fluctuates.
from the State Department of Health, man.
No,
their numbers, you can't get anything from them.
that number fluctuates because in the beginning, most cases are unidentifiable, right? Because the contact tracers haven't done their work. And as we go, as the time, say today is day 0, right now, all the cases that come positive from today, they're all going to be in that category. But as we look, as a week goes by and the contact tracers do their job, and what, that entails, they're doing a really good job when they have the right evidence. And so that means they talk to somebody, they're like, hey, where have you been in the last usually 2 to 3 days before you develop symptoms? And we can get into why it's actually, you need to go back before you develop symptoms, because you are infectious before you develop symptoms. Who have you been in contact with? Where have you been? And when you were in contact with that person, if it's a person who is actually was in contact with a positive person, what was that interaction like? Were you both wearing masks? Was just one person wearing masks? Where was it? Was it inside? Was there ventilation in the area? Were you wearing glasses? Did you hug them, or did you, share utensils? It gets very, very detailed, and they're doing a terrific job. But sometimes there's just dead ends. Charlie, you were a police officer, right? And like sometimes there's just dead ends, and people are like, either I don't know or I don't remember. And look, I don't really remember where I was 3 days ago exactly, but most of I know I pretty much just go to work and in my house, and in my parents' yard really is where I only go. But they're doing the best job that they can, and we're going to need more of them. When we have this many cases, we're going to need more, and they're training as many as they can. But there comes to a point which we've seen in every municipality where contract tracers just get overwhelmed. Even no matter how big of an army you have, you can't keep up, and we can't get to that place. And if we keep going on this trajectory, we may reach that if we haven't already.
I think sometimes we've always been curious. You gave a whole slew of things that I'm glad you said it. The type of questions asked. You really got to push hard, because sometimes people just they won't cooperate. Some just, they don't like government. They don't like being asked questions, so they may just say something just to get you off the track. Sure. I've never heard anyone yet so far, and maybe they have. If they know they're coming from a bar, I haven't heard anybody trying to pull videos off the bar. Getting access to the video surveillance that's inside the bar, because these individuals, like if I'm talking to you, you'll probably tell me the names of people that you absolutely know, but the person on the side of you, I'm sorry, but the person on the side of you that was relatively in close contact with you, and you may not know that person. And so, yep. What we said all along is get as much help as you can. And you notice 4 months ago, Mel and I had been beating this thing to death about, hey, why can't the Department of Health just tell us, we're not asking for names, but just tell us where the infection occurred. Oh, you can't do that because of HIPAA. And we know that wasn't true, but they just didn't want to release that information. You look at these last couple of cases, we know that Hawaiian Brian's, we know the name of the 2 bars. They're starting to name all the places that's these infections are coming up. And I think it's good, because people will be cognizant and responsible and maybe turn themselves in and say, I was there. I may be asymptomatic. Can I go get tested? Let me get tested out. So I think those are the kind of things that, I really wish, and I hope and pray that the DOH is pushing for, because it goes that next level. Like you talked about police work, right? The patrol officer will get so much he can, then he turn it over to the detective. The detectives will get so much he can, then you take it over to the next specialized unit. But the thing is, sooner or later, if everything is made in heaven, we should actually circle back to the origin of how this virus came, correct? But right now, we can't even get there. So what we know is, in its early inception, we know it came in from travelers. it came and it laid the seed here. Now it's trying to find out where that spread went and trying to, I guess, hone in or put it in a corridor that we can control it. And I wanted to ask you after that long summation, do you think, based on what you know now and based on the numbers that came in, do you think they'll be able to bring it into that corridor to control it?
We can, as long as people follow the recommendations that they've been stating since since this virus began, is wear masks, physical distance, wash your hands, and don't gather in groups. Right now, I think larger than 10. If we continue to, it sounds like repetition, but that's really what we need to do. Is that masks every day? There's more studies that come out on how effective masks are, and since the last time you and I talked, there's been an inordinate amount of studies. There's been a study that is about to come out of a factory in Spain where everybody was wearing a mask, and the percentage of those factory workers, and there was close to 1,000 of them, 95% of them who were infected were asymptomatic. And so what that tells us is that there's perhaps not just a protective mechanism from masks to the population, meaning I'm not going to spread it to somebody else, but it's likely protective for you, and meaning that you get decreased viral loads when it gets into your lungs or gets into your nose or into your mouth, and they hypothesize that it's the decreased viral load that actually causes you to have possibly more chance of an asymptomatic infection or less of a chance of being really, really sick. So there's protective measures that seem to be coming up with masks. There's a study that came out of Beth Israel, Harvard, one of the Harvard hospitals, where they could clearly show when people started wearing masks, the infection weren't wearing masks yet. The infection rates are going up, up, up. They started wearing masks, it flattened out, and then actually went completely down. And so masks are not the panacea, definitely not. I'm not saying that. And it doesn't mean like, hey, look, because we're wearing masks, we can gather in groups of 50. It just means in combination with limiting how many people you come in contact with, in combination with wearing masks, in combination with good hand hygiene, that's all going to help to bring this back to levels that we can handle. Because right now, all of these spikes, 124 persons who've contracted this illness, 10% of them, maybe more, may end up in our hospitals. And right now, even a bad flu season, when we reach the falls and wintertime in January, usually flu season starts peaking in January. That virus is, like I said, not nearly has as high of a mortality rate and isn't as infectious. That puts all of our hospitals like almost bursting at the seams sometimes. There's like, when I'm working in the ER here in Honolulu, like every hospital is what we call reroute, meaning like we're so busy, like please go round robin, like we can't just take an influx of patients. And so that's what we don't want to reach. And there's only a finite amount of medical care that we have here in Hawaii. We don't have the luxury of shipping or moving our patients to another state. So we have to be careful, and we can't let this burgeoning, brush fire turn into a huge raging forest fire. And that's what we're flirting with at the moment.
Mm-hmm.
Yeah, and I think it's always been the concern. I know for Charlie and I, anyway, the limited resources that we have, and if we got to share that resources with the flu, with the other diseases that people need to be admitted into hospitals, and that's why. I don't understand why, reactive, we're being so reactive when we should be being proactive. And I'm talking about the people. I'm talking about the residents that fail to use their masks, that fail to practice clean hygiene or safe hygiene, and fail to practice social distancing, because I think sometimes they get complacent because of the low numbers, especially on the neighbor islands like Kauai. Yet if we get one big cluster like they did in Oahu, if we get 100 cases, which is highly possible here, with one infectious person that is part of that disregard for health and safety. I posted a study, and you probably saw this video, that the Florida Atlantic University did the study on the different types of masks, and they start off with the video with no mask, and then they go into the different types. But if you
was that the silhouette one?
Yes.
The silhouette with the light? Yeah, okay, yeah.
I mean, that basically tells you that the mask helps. The mask will reduce the threat of spreading the virus. Not 100%, but I mean, that in and of itself should force you. And we see so many gatherings today. We drove past a funeral in Hawaii, and I gotta say, while there are a lot of people there, in fact, my wife said, "Wow, Mel, they're all wearing the mask." I mean, they were all wearing masks from what we could see anyway. At the time we passed, so that was very refreshing.
Good.
But that's not always the case, and the social distancing is very difficult when you're at a funeral or some kind of gathering like that. Now, I had a chat with a guy today who's or a woman actually today that had a relative on Oahu that was working for one of the county agencies up there, and the coworker tested positive. And they work in a truck. They're outdoors, they do their crew, so they're in the same truck. Anyway, long story short, one of them got sick, tested positive. So all of the other crew members got sent home on quarantine. They didn't get tested yet. They just got quarantined. 12 days after, the 12th day of quarantine, he started to get symptoms. No fever, symptoms, minor symptoms, tested positive. And then his symptoms got a little worse. My point is this, on the 12th day of quarantine. So, and this is leading up to my question about the inter-island quarantine as well as the opening of tourism on September 1st, and relying on one single test, or schools opening with the reliance of a temperature screen. How many cases, Doc, are we seeing that are testing positive? And I know that the old saying 40% asymptomatic, but even the ones with symptoms, what's the percentage of people that do not have a fever? Do we know that number?
The fever, about 80% of people will eventually mount a fever, but sometimes you don't mount that fever. That's not the first symptom you have. Sometimes it's fever, a little fatigue, a little sore throat. And I actually can go through a couple of slides that I presented that kind of go through all this if you guys feel like it's a good time to do it. Yeah. Okay. So if anybody's watching on a phone, I'm sorry if this is not going to show up for you. Let's see. Can you guys see my screen?
Yes.
Yeah, we can.
Okay. All right. You can see my arrow as well, and everybody can still hear me. Okay. So, we've had plans in the works to market Hawaii as the safest place in the world. And this is strictly from an economic standpoint, right? Because this, while our economy is kind of faltering and definitely on its last breath, that is also harming completely the health of all of our families here in Hawaii. There's people who can't afford to, even keep a roof over their head. They can't afford their medications. It's really, really, when our economy slows down, both the health of our citizens. So this is, not just, it's a very complex issue. And it's something that really kind of speaks to a lot of getting everybody in the same place and everybody having the same discussion. And there's a lot of heads that need to come together. So it's no simple task, but there's a couple of really important points that I wanted to kind of put together. And exactly what you said, Mel, here, there's, the symptoms. And so there's about 87% people will go on to develop fever. But again, if you take Tylenol or ibuprofen, if you put this in the context of a one-test screening protocol, right? Screening protocol before people get on a plane and come here to Hawaii, there's, that can easily be gamed. And I think if somebody's going to be spending $5,000 to $10,000 on a trip to Hawaii for them and their family, they may, be pretty inclined to spend $5 on a bottle of Tylenol or $10, whatever it may cost. Here's a list of symptoms that go on from dry cough to fatigue and the rough numbers that people have, percentage of people that have them. And then one that came up later that was kind of very subtle is that people were starting to have anosmia all the way down here, or hypoosmia, which is basically no smell or lack of smell. And about 40%, one study showed 40% of people will go on to have some sort of anosmia, and another had 44% had just a little bit of lack of smell. And they only were able to detect that when they actually held up a bunch of different smelling sticks. So you may not even notice it. Just like, oh yeah, I can't really smell coffee, or can't really smell some other certain smells. So it's very kind of subtle. And so two real periods that I think are really important to talk about when you talk about when, exactly what your question meant, Mel, was when is this test actually useful, and when do we get a lot of, when can we get false negatives, is the latent period and the incubation period. So this is a lot of kind of a busy graph, but I just want you to look at these two bars here. Is that the latent period is this gray bar, and this time 0 is when you say you were to become infected with the virus here, become in contact with it, and you became infected. Say this is day 0, or the pre-flight 72-hour test. You took it here, and you actually become infectious a couple days before you start having symptoms, which is this blue bar here. And so say you get on the flight at day 3, you haven't had to start this, you haven't started to have symptoms yet. And so you can be infectious before having symptoms. And that's what's caused this virus to spread globally, really, is that you can infect other people before you start having symptoms. And that's what's been hard compared to SARS, which was the original coronavirus, SARS-1. This bar here where you started having symptoms was actually way closer over to the left, meaning that when you were infectious was only started when you started having symptoms. So if that makes sense, I'll move on to here, this is another busy one. I just want you guys to look at this one up here. And this is how effective is one PCR test. And so this is days as we go to the right. All the way over here is about day 5. And this is the average. Day 5 or day 6 is the average amount of time from when people are exposed to the virus. If they're exposed on day 0, day 5 is the average amount of time that people will take to develop symptoms. And in these first 3 days, so this is day 0, day 1, day 2, day 1, day 2, day 3, and day 4. If you notice, in day 1 and 2, this is the percent of the chance that you're going to have a false negative, meaning that you take the test and it's negative, but it's falsely negative because you actually have the virus. And I'll tell you why in the next slide. But in day 1, 2, and 3, it's pretty much 100%. Day 3, you see a smidgen of effect here, but it's almost 100% chance that you're going to have a negative test. It's only once you start mounting a higher viral load that day 4, you see like, all right, so there's a less of a chance that you're going to have a false negative. You have about a 70%. Day 5, you've got about a 45% of having a false negative. And it actually peaks, the efficacy of our most sensitive PCR tests actually peak at around day 7 and day 8, all the way over here. Okay, and I'll show you another reason why having just fever screening, which was another question of yours for schools and also for our mainly our pre-screening protocol when people get on the flights, how many people are actually symptomatic? And this was a large contact tracing study done in Italy, and this yellow, these colored codeds are how many people are actually symptomatic. And the gray colors here, here, and here are actually people who are critically symptomatic. They need oxygen, they need to be in a hospital, they possibly could be on a ventilator and later perish. And so you look down here, as we all know, that the older you get, the more chance you're going to have high rates of comorbidities, but also your immune system isn't working quite as well. So you can see there's a larger percentage of people who are older who get sick, and we know that, and also who get ill. But what are these total numbers? 82% of our younger persons are going to be asymptomatic in this study, at least. 78 are going to be asymptomatic in this age group. And then from our 40 to 60-year-olds, 70%. And then 65% of these age groups here, so on to only about 35% of our 80-year-olds are going to be lucky enough to be asymptomatic. And so what are the age groups that's going to be traveling here to our islands? I would guess, hypothesize, and probably HDA has a better idea of this, that, the people who are above 60 aren't going to be willing to travel just because it's just really, really high risk. They're not going to be traveling. So we're going to have probably a lower percentage of people coming to our islands. And look how large of a percentage that is that are asymptomatic, usually like 74%. So fever screening, while it may catch some, it's really not going to catch much. And as I mentioned, fever screening can be gamed with Tylenol or ibuprofen. Now here's a CDC best estimate of, I just want you guys to look over here on the right. The best estimates of what the viral dynamics are going to be. And R naught is, I think, a term that a lot of people are familiar with, but if you're not, it's basically the number of people, average number of people that one person will transfer it to. And they have a bunch of different scenarios here, but the current best estimate is about 2.5. Now flu is about 1.3, as I mentioned in the beginning of this, our discussion. So 2.5 is quite a large number when it comes to upper respiratory illnesses. Measles is all the way up near 13, but when it comes to you know, something that's twice as infectious as flu, that really makes you kind of stand up. And what is the best estimate for overall fatality is about 0.0, this is going to be 0.6%. So 0.65, and as I mentioned, flu is about 0.13. So percent, that is. And so it's about 5 times as infectious as flu. Now, as you mentioned, Mel, 40% are probably going to be asymptomatic. That's in all comers. But as I mentioned, as you get younger, there's a higher percentage of asymptomatics. How infectious are you when you're asymptomatic? And the best guess right now is you're roughly about 3/4 as infectious. So you're still plenty infectious, even though you don't have symptoms. Right, and so they estimate, and I think this is probably a little bit low, but the percentage of transmission that's occurring prior to ever developing symptoms, if you do go on to develop symptoms, is about 50%. So that's pretty high. And I'll tell you why that happened. So bear with me. If you have any questions, please feel free to interrupt and let me know. But here we go. We've got our typical x-axis, which is days since exposure, day 0 over here. And this is basically your viral load. And this test here, this red test, is a very sensitive PCR test. You know, the one that goes all the way back in the back of your nose. These are the most sensitive, most expensive tests that we can get. And this test over here is in the brown, is basically a less sensitive test. It's probably an antigen test or one that's just not quite as accurate. So even if you have the most sensitive test there, like I mentioned, those viral loads, this is your viral load here. It's almost like a pregnancy test in the sense that pregnancy test isn't going to be positive in the first, you know, couple of weeks of pregnancy. That pregnancy hormone has to kind of skyrocket, it has to go up. So even the most sensitive PCR tests are not going to catch virus in those first 3 days. It's only when the viral load starts going up here, and on day 5 or 6, this is when you start having symptoms, it gradually decreases. So your viral load actually peaks before you start having symptoms. So you're usually more infectious the day before you have symptoms. And so viral load continues to be positive all the way down here. Sometimes viral load will be as positive for as long as 3 months. And that's mostly what we think is viral remnants. It's not actually replicating virus that can cause infection, but pretty significant long tail here. And so this is kind of really following the same pattern that we're seeing here is, again, days since exposure, and your relative infectiousness, meaning like this is as high as infectious that you can be. And that, again, look at peaks before you start having symptoms on day 5 and 6. And so in this black bar here, you say your viral load is building, you're actually really infectious right here. You start having symptoms, and then your infectiousness actually goes down. Okay. And most of the CDC has recognized this, that most infectiousness is gone if you have mild symptoms 10 days after you develop the symptoms. So you can see if you started to develop symptoms at day, right here, let's just call this day 6. It's pretty safe to say by day 16, if you just had mild symptoms, you're not going to be infectious anymore. So that's that kind of built-in buffer that the new regulations they just came out with. And here, I think, is kind of the money graph. If you tuned out, this is one to tune back in with. And this is a terrific modeling study that was done by Dr. Michael Mina. He's both a molecular PhD expert and MPH at Harvard Medical School. And they did, knowing that all of those viral characteristics that I just went through, knowing that the viral load builds and that our PCR tests are actually not picking up the first 3 to 4 days of symptoms, they put into a big model and put all those characteristics of our tests in, and they did a 10,000 patients. So let's just say this is about 1/3 of where our tourist load could be at some point. So, you know, our tourist load peaked at 30,000 tourists per day. Let's just say this is a third. So right now, if you were to just test everyone just once, you know, I've heard estimates of up to, you know, that'll remove 70% of infectiousness. I think that didn't take into consideration everything I just went through. It really, according to this study, this red bar here is that very sensitive test. This brown bar is that less sensitive test. And so what Dr. Mina was saying is that really, whether you take a very sensitive test or a less sensitive test, if you're trying to screen in a group, and this isn't for diagnosis, this is for screening for you know, our arrival protocol, that really it's test frequency that actually removed the infectiousness. So that's what this graph here is here. So if you were to just take one test before people got here and then they didn't take any subsequent tests like our prior program was, you're going to remove only about 30%. And then with symptoms, maybe a little bit higher at 40%. If you were to give our tourists a weekly test, you're going to remove 60%, maybe a little bit higher to 70%. If you were to have our tourists take a test every 3 days, which is like what the Bahamas protocol is, they have to take a test up to 5 days before they arrive, a test when they do arrive, and then a test every 3 days while they're there on the Bahamas, they're removing about 90% of their symptoms. Now, if you were to give everybody a test every day, excuse me, not 90% of the symptoms, 90% of the viral load in the population. Now, if you were to give everybody a test every day, obviously, you know, it's pretty hard to do with the amount of testing that we have here. You're going to remove 100%. And so if nobody gets a test, the only people that have symptoms are going to be filtered out. So I guess in summary, but presenting all those slides is that if we only test once 3 days before, we're only going to remove this amount of people. And I've been trying to increase our awareness of pooled testing. And back in early June, and to increase our testing capacity, I approached Donovan Dela Cruz and got all the lab people together at DLS and clinical labs and our Department of Transportation as well. And also DOH, Sarah Park was there, and that, you know, let's get the pool testing is a method that's been used in the past. It started off actually with a doctor back in the 40s who was screening people for syphilis into the Army. And basically he put a bunch of the test tubes together, grouped people into 5 and said, hey, look, if this group of 5 people is negative, like this one, say here, then I could just move on. And so that's what this is. This is 100 people that have been grouped into groups of 5. And 5 of them, these red dots here, ended up being positive. So all of these people who aren't in a positive pool don't have to be retested. So in this segment here, instead of running 100 tests, you actually ran 45 tests. So you save testing capacity, the reagents, the swabs, and that sort of thing. And so I'm really happy that it seems like our Department of Health and you know, state administration is actually moving forward with this. So that's great. And obviously the pool testing only works if everybody here was positive. You're not going to save much tests, right? So pool testing only works when there's a lower percent of people. So if we have got a 5% positive rate, like we've been having, you shouldn't be batching more than 5 people into one pool. But if you've got a really low prevalence rate, theoretically, if the labs can theoretically do it, practically do it, excuse me, you can go as high as, you know, 11 to 33, but that's pushing it. I think if we safely, there's some instances where pooling is not going to work, but if we're doing massive screening, like say in our nursing homes, where it turns out our prevalence is turns out to be only a couple percent, pooling is a good way to save reagent capacity. And if you think of it, like, what are the testing protocols that we have, Mel, in the NBA and in the and Charlie in NBA and other sporting industries? Is that what they do is you got to be in quarantine for a week. You got to test twice before you get into that bubble. The film industry does this too, and then you've got to test every single, usually every other day, or some people are doing every day or every third day. So that's how they are removing all of the infectiousness like this. But I think if it's good enough for you know, the NFL, for other industries, that we should definitely think about, you know, testing and a lot more frequency. And it doesn't have to be those really sensitive tests. It could be these less sensitive tests. But we need to get a hold of those, and some of those are becoming FDA approved, and that's also, there's a lot of moving parts to it. But if we don't test again, we're going to allow a lot of infectiousness into our state, and the options, I think, are either test again, or we're going to have to really restrict our movement of our tourists. So if you have any questions, let me know. I don't know if I blasted through that fast enough or too slow, but let me know.
I'd like to ask you, you know, I'm going to start fielding questions from the viewing audience. And one of it is from an individual who's asking the chart. I guess one of the charts you showed, they claim it was from a 2006. Is that? I mean, I don't know what they meant by that, the data.
I don't know.
Okay.
I don't know. This virus hasn't been around since 2006, so I'm not sure.
Yeah, that's what I kind of figured too. But you know, she's watching, so I just wanted to let her know it's a female that she's asking about that chart of 2006. Now, Doc, regarding the bubble, you just mentioned about the bubble, and we've been hearing this. I know that in order for that bubble to work, and say it's a family pod, right? Say a family of 5. In order for that to work, wouldn't everyone have to be tracked to make sure that when they come back home and they come back to the family unit, they did not go somewhere where maybe they shouldn't have gone, or come in contact with somebody they shouldn't have come in contact with, in order for the bubble to be sterile, to be that you have.
Are you talking about bubbles just in a private house?
Yeah, just in private house.
That's correct. I mean, if you're talking about just in a private house, exactly. And so people have to be, if they want to make their own house into a bubble, they have to be very strict with honest with where all the family members do go. Okay. And one way around that is actually, you guys mentioned contact tracing, and there's some things that are coming up in the pike, hopefully, that are digital contact tracing applications where, you know, it's less invasive than our, you know, if you have your map, you know, like a GPS on, your phone is actually pinging servers. And so data is leaving your phone and coming back to your phone. Whereas the applications that are coming out now, they're more like a digital diary, in that your phone is just logging where you've been via GPS, but it's just logging where you've been in the last 2 weeks. And so it'll really help our contact tracers if you do end up being positive, or you do end up being next to a positive person, that you can pull that up and be like, oh yeah, I was here, and they can go through that with you. And it'll be it's more of a memory tool, and it's not tracking. It's not like actively following you. It's not Big Brother. It's just creating a kind of a digital diary of location on your own phone, and you only release it if you come positive. And it's de-identified. It's not, you know, telling everyone, oh my gosh, somebody's positive, somebody isn't.
Okay.
Yeah, we had a discussion about the QR code scanner that South Korea uses specifically for contact tracing. It's not Big Brother, but and it was presented to the State Department of Health, to the governor, and we actually I sent that PowerPoint presentation to the Senate COVID committee meeting, because you know, if we knew, I don't remember where I was a week ago, 5 days ago.
Yep.
But with this QR code, you cannot gain entry into any store or bar or restaurant unless you scan your code. You scan with your phone, and when someone tests positive in that establishment, then all of the data gets sent to the Department of Health. Just the phone numbers, though, no personal identifiers.
Sure.
So, and then
even that is more a bit more invasive than what these ones are coming, you know, proposing.
So I mean, it's just we got to get a handle it. Now, I had a specific question because you talked about the current plan for September 1st is one test 72 hours before. Well, we know we're going to have some issues because just testing maybe just getting a test now in many places on the mainland is going to be difficult. The Kauai discussion group talked or presented a proposal, which was basically a two test series with a 6-day quarantine. So you take a test before you, or when you leave your day, and then on your 6th day of quarantine, you take another test. If you're negative, then you're free to go. And we know that, you know, even 6 days, you still could be contagious and still test negative. But the chances are greatly reduced with a 2-test system.
Absolutely. Like that graph that I showed is, you know, from 30% to about, you know, 70%. So
yeah,
the 2-test system gets to 70%. So that's a lot better.
And I just don't see the state going down into that direction. I think one of the questions or the concerns was about the testing, but your pool testing now. You take your pool testing and you put a lot of these people. You could put 5. You could probably put more than 5, right, in one pool. But you could do that.
You probably could, but then it defeats the mathematics. It defeats the efficiency of it if the prevalence rate is high. But also the problem with it being is that you know, these labs have to follow FDA certifications, and the labs actually have to submit to the FDA, hey, look, I'm going to start pooling this many samples with this machine, and the FDA has to go, oh, okay, I clear it. But Nebraska got around it because they utilized that their state was under a state of emergency. Their governor declared a state of emergency and an emergency proclamation. So the labs were like, you know, we don't need an FDA approval because we're just gonna we're in a state of emergency and we're gonna do what works for us. And so there's a lot of moving parts. It's definitely a simple answer, but behind that answer is a lot of operational requirements.
So even if we went with 5, I guess the point I'm trying to make is that there is an opportunity for us to use less testing resources and on a 2 testing system for the specific purpose of this travel quarantine. If we went to a 2-test system with a 6-day quarantine,
sure.
that could work. I mean, and it could really reduce the threat or the chance of infectious people being released. Now, if you guys just joined us, someone just wanted to know who you were. They came on late. Dr. Darragh O'Carroll is an emergency room physician over there at Kuakini Medical Center or Kuakini Hospital. Also has been a very active in COVID. Worked with Netflix, right? It was a Netflix documentary. What was that?
Sure. Yeah. That was it was called How to Prevent an Outbreak. It came out in 2020, and I was a medical consultant and basically was in charge of making sure the series made sense, and then also casting. And so like who's doing what. And so I interviewed Dr. Fauci and Dr. Rick Bright for about an hour each, and trying to pick their minds and what they do on a daily basis, and presented them to the production team, so to speak. So I can assure you, Dr. Fauci is as likable as he is in person on a candid phone call that he has been on the news. So,
well, we tried to get him on here, but I know his time is busy. So,
yeah,
it's one of those things.
Yeah.
Anyway, you know the question I asked you earlier again, Doc. I guess some of the viewers are questioning the. You know that chart you showed with the delay in symptoms?
Yeah.
Delay in symptoms.
You want me to pull that up again?
Yeah.
Let me share screen again. So, yeah. Which one were they saying? Delay in symptoms.
Yeah.
Probably, oops. Probably that one. This one. There you go.
Yeah.
Day 6 is exposure, and then you're infectious, but you don't really have symptoms till day 5 and 6. And so this period, again, this is your incubation period, the time between you have you're exposed to when you have symptoms. The latent period is when you're exposed and to when you're infectious. And so that's what's driving this virus globally, and what it's exploded globally is that these don't overlap. Usually, with flu, you have an incubation period of about a day to 2 days, and then your symptoms develop right after that. And you're not really infectious for very long before you have symptoms. But you're infectious 2 to 3 days before you have symptoms, if you even go on to develop symptoms, because so many are asymptomatic.
Okay.
Yeah, I'm
Right.
not sure what the question about the slide is. I mean, if you want to post a question about the slide, post your question. I'm trying to backtrack to the comments and I'm not seeing what the question is. And I'm not sure what they're talking about 2006 data. Um, I don't know.
Yeah,
I think
maybe
the
it's a
premise
typo.
of the,
It's pretty close to
yeah,
2016, but I don't know.
yeah, I mean, COVID's only been around since 2000. This COVID, the COVID-19 has been around since 2019. So I'm not sure. Show the file name again, please. I don't know what file name they're talking about, but anyway,
Oh,
you know,
okay. I could, you know what? I can text it to you if you want and send to everybody afterwards, or put it in
yeah, I'm
a
not sure
comment.
what file name. Um,
I think it was this one, the MedRex number. I'm going to show it one more time. Sorry, guys. I
Yeah, you know,
apologize.
I'm not sure what, you know, listen up, people. Again, you know, our policy here is not to put people on the spot, but we're also not gonna run away from your questions. If you're concerned about the validity, I can tell you, you know, Dr. Darragh O'Carroll has been around for quite a while and specializes in the COVID. So if you disagree with the concept of testing visitors, then that's fine. That's your opinion. If you disagree with quarantining our mainland visitors coming from hot zones, that's fine too. But this is the data. This is the data that we're
Yeah,
looking at.
and
So
I think our state, I think our state leadership realized that, and they realized, you know, it might not be a good idea to go ahead with just a one PCR plan, you know, one test plan, and they realized, oh yeah, let's. I think they did a really good job in getting that far, but you know, they need to go a little bit farther, you know, and I have faith in them that they're gonna reach a bar that is more acceptable.
Now you said that, you know, with regarding the mask, wearing of the mask and the data that came out with that. Um, you know, there seems to be this question, and a lot of it is whether we have enough compliance or not. Do you feel that the state should, you know, go into a heavier enforcement of that? If that's the real part of the reason why this infection is spreading is because, you know, large gathering, no mask, indoors.
Mm-hmm.
Do you think we should go to a stronger enforcement as because right now things seem pretty complacent. You know, people always ask, you know, you guys wearing masks, but nothing is being done. You know, that kind of talk that we hear a lot.
Yeah, that's a really tough question, and I don't have the vantage point, Charlie, that you would have, and how exactly does enforcement would that look like from the
Yeah.
police, and who's going to be doing it? Do people just, you know, walk in and do a random inspection of each establishment? Are you wearing a mask? Are you wearing a mask? Most establishments are doing a pretty good job of doing it, but do you enforce it out in the public? That's a tough question, and it would help. It definitely would help with viral transmission. But the logistics and operationalizing it, I don't know how possible it may be. Look, I think probably a better way is just to keep getting good public messaging out there. Just get, you know, repetition that like wear masks. And sadly, it may be human nature for a lot of people that, you know, most everybody in New York, after they saw how Manhattan and their state was decimated, are now like, okay, we should be wearing masks because we don't want this to happen again. Sadly, it's human nature that if it doesn't actually affect you and personally you see or your life is tragically affected by it, they may not wear masks or do the things that are needed. I hope Hawaii doesn't get to that state, and I hope that Hawaii you know, realizes that it's what's good for all of our state, our kupuna, our you know, our most vulnerable persons, and that's not what Hawaii is known for. It's not putting me first. It's for putting everybody, the community first. And I think we can get back to that.
Okay.
Yeah, I mean, I think when you start looking, I mean, New York. I remember when Seattle when you know Washington State was the hot zone, and then you know, it was like wow, and no one. I still think, even I had some doubts that it would ever get like that in Hawaii. Then New York, and you know those East Coast states, and then Arizona and Texas and Florida, and now Southern California. And I think people are now starting to be concerned. I see more people wearing masks. I think you're exactly right, Doc. Is that messaging, that public messaging, and that everybody needs to be complying. Because we had Dr. Kimball on from Arizona. Actually, he was in Arizona. He's there. He's doing. I mean, I'm sorry, Utah. In Utah, he's doing. He's an emergency room doctor up there as well, and he was shocked at how quick they went from where Hawaii was 2 months prior to blowing up. And he was trying to get that point across to our viewers, was that this thing is, that's how this virus works, and just a little bit of complacency can turn this thing upside down. And I think people, I'm not sure how to get that message across.
Sure.
We've heard that the masks, and like I say, I think the compliance with masks have gotten a lot better, but still we're still far from where we need to be. And,
you're right. And
go ahead.
You can illustrate it, and people can visibly look at it, that those graphs that we see of infectious rates, they're very steep in the beginning. They're really, really steep. You've got like 100 cases and all of a sudden it doubles to 200 to 400. Those are really, really steep. And so if our mask rate continues to stay low, we're going to see a really steep incline. And all of those infectious people that tested positive a couple of days ago, all 124 of them got infected on average 5 to 6 days prior. And so it's a lagging sign. And so we could be there. We could be at that point right before. All my colleagues who I trained with in Los Angeles, who are working across the state, all said, hey, look, it just exploded in front of us. And we could be right at that point. And so I think everybody needs to do everything to minimize that possible explosion.
Now, Doc, because of this recent frontline doctors, you might have thought it was Stella Emanuel or Stella or Stephanie, I don't know which name it was. Again, the promoting of the hydroxychloroquine, azithromycin, and zinc. What's your take on that? Because they're, like for lay people like us, we're just
I hear you, and
it's confusing.
It's very confusing and it's unfortunate, but I can't speak to her morality as a person and as a physician. She has that specific physician you mentioned has said, some crazy kind of things in the past, that, there's alien DNA that's infecting people, and some really kind of outlandish statements in the past. But here's the stone cold hardcore fact. Is that the FDA, the body that regulates what medications are safe and are safe to give, has revoked the emergency use authorization for hydroxychloroquine because there's an inordinate amount of evidence that it does no benefit and actually causes harm. And so there's a thing in medicine called equipoise, right? If you're trying to study, is option A or is option B better for my patient? I have no idea. And this being hydroxychloroquine or let's say a placebo, that's ethical to give to a patient, right? Because you don't know. And the first thing that everybody, the Hippocratic oath that every physician takes is first do no harm. And so if you have no idea that option A or option B is better, you're ethically okay in giving those. But there's so much data that says hydroxychloroquine doesn't help and actually can be harmful, that I think we have lost that equipoise, and that we know hydroxychloroquine doesn't help and it can actually harm, And so the FDA has revoked it, the CDC has revoked it. Nobody is using it for treatment. The question is possibly still out, is it okay for prophylaxis? Meaning like, does it actually prevent you from getting it? But there's been a very good study that said post-exposure prophylaxis, in a big study of healthcare workers who immediately knew that, oh shoot, you were just around a positive patient. When they started taking hydroxychloroquine, it didn't help them at all. So the question is, does it help before you're even exposed? That the answer is unlikely no, but we don't have the complete answer yet. But when it comes to treating this disease, the answer's out, is that we've lost the equipoise. I'm not going to recommend, ethically, my duty as a physician is to do no harm. And I'm not going to recommend a treatment that I believe at this time has so many studies showing that it does harm.
Okay.
Well, we
Well,
know it
that's
didn't
why
help. We know it didn't help Charlie's brother.
Yeah.
You know that's one. And you know,
Um,
again, there's thousands
sorry,
and
Charlie.
hundreds of thousands of cases out there. You know, the problem is when politics get involved, and then you get that political mudslinging back and forth for whatever reason. I don't care if they came out and take COVID out of it. It doesn't matter right now. It's election season. People take advantage of any type of decision made, and they politicize it. That's why I like bringing doctors on. I don't like bringing politicians on. I like bringing doctors on because it's factual data. Factual data. Now, Doc, I have a question. It's a medical question from someone that is in the medical field. And she says, I've seen patients who have normal white blood cells with COVID-19, which I've not seen with other infections, viral or bacterial. Does that make sense? Or can you
Yes.
comment on that?
Absolutely, yeah. So that's one of the hallmark kind of strange things about this virus is that typically, so white blood cells are a big category of cells. You got your white blood cells and red blood cells. The red blood cells transport oxygen and carbon dioxide, but the white blood cells are really our immune system cells. And typically when you're infected, and your commenter is completely right, is it can be a sign of, and is usually a sign of infection, that when your white blood cells, when you have an infection, your white blood cells go up because they're trying to fight this virus or bacteria. So there's a lot of immune cells going around. What we're seeing in this virus is maybe no increase or just a slight increase in white blood cell count. But what we are seeing is a decrease in lymphocytes, which is a specific type of white blood cell count. So if you see a normal white count and a low lymphocyte count, that's what is predominant laboratory signs that we're seeing in patients with COVID positive, that come in COVID positive.
Mm.
So it's strange. Yeah, it's throwing us through loops.
Okay, good. Yeah, because she was a little concerned and wanted to get your take on it. And so I hope that got your question answered. What immune boosting supplements does Doc recommend?
You know, there's some studies out there. Originally, they were given high dose vitamin C in China. That didn't seem to work. I don't think it's going to hurt you if you just take some vitamin C. There's some preliminary evidence that maybe vitamin D might be somewhat effective. So vitamin D may not help. Getting a lot of sleep, keeping your stress low, keeping your vices to a minimum, stop smoking now, get some daily exercise, those sort of things. Eat right if you can. But if you were going to take anything, multivitamin, vitamin C, vitamin D, that's what I'd recommend.
Hey, Doc,
I have a stupid question, just a real quick. Sorry, Charlie. Edible multivitamins. Did it work?
Oh yeah, I mean, you're not going to absorb the vitamins in as well as if you were to eat, leafy vegetables and have a good hearty diet, because your body's able to absorb those nutrients a lot better. But a multivitamin, an edible multivitamin, yeah, you're gonna, a lot of them are packed with like 200% vitamin C, so you're definitely gonna get your daily dose of vitamin C.
I guess the better question is edible versus a pill or capsule. That was the question.
Oh, like gummy versus.
Yeah, gummy.
Okay.
Sorry, I should have made it clear.
That's okay. Yeah, I don't know. I can't foresee any digestive differences or mechanics. Whatever tastes good and whatever you like to eat. If those gummies taste good, then sure. If it's easy.
I cannot for the life of me. I can't eat gummy bears, man. That stuff bothers me. But this this multivitamin that we take now, these gummies, I can eat that one.
Good.
Hey, Mel,
there's.
Just stick with the Flintstones. Just stick with Flintstones.
It's so good. Like, you're supposed to have 2 every day. You're supposed to eat 2 of these gummies. Man, I was so hungry the other day. I had like 14. Oh boy, it felt good.
You can get vitamin toxicity if you take too much. So be careful. You don't want to overdose.
Just kidding.
Yeah.
I was just kidding.
Lechon. With regards, we talked about hydroxychloroquine. What about the azithromycin and zinc? What has that shown?
Same story.
Same
Same
story.
story. Same story. That especially when you take hydroxychloroquine plus azithromycin, both of those do the same thing to the electrical activity of your heart. It actually prolongs a certain recovery period of your heart to the point where you can have a heartbeat on top of another heartbeat. It's called a R on T phenomenon, and flips your heart rate into a fatal arrhythmia. And so that's the danger when people say heart rhythms that develop when you take abnormalities that develop when you take these drugs. That's what it is. It prolongs a certain recovery period where your heart's supposed to be resting, and can flip you into a fatal arrhythmia that you can't get out of.
So I guess in the early stages of this pandemic, for those doctors who use hydroxychloroquine with their patients, and the patients passed on, could that have been the cause for their, I mean, I know we don't have a report in front of us, but it seems like it causes more harm than good if it could, accelerate a person's, demise, really.
Where it would cause harm is those fatal arrhythmias that I mentioned. So there has been deaths that have been caused by those fatal arrhythmias. Whether it actually accelerates the demise of, accelerates the virus, we don't know the answer to that question. Definitely not. But it actually can cause harm in low blood pressure, or those fatal arrhythmias that can cause death, or cause someone who's actually just on nasal prong oxygen. They go and flip into that fatal arrhythmia and they have to be intubated or something of that nature, and causes them to progress down a course that they shouldn't be. So, I mean, that would be a case-by-case basis.
Okay.
Well, we're almost at 8 o'clock. I'm just going to ask you the tough question right now, because this was a topic of ours the last couple of nights. School, allowing kids to go back to school. And I'm going to ask you a political question of when you think they should open, but kids that go to school, they're getting a temperature scan. I know I talked a little bit, I asked part of that question earlier. They'll wear masks, try to do social distancing. How dangerous is it for kids to be running around from all the different range of ages, from the elementary to the high school, and the ability for them to transfer this virus? Is it, I know you saw your chart earlier with the ages as far as symptoms, but how safe are our kids with just temporal or temperature screening or scanning, and no other type of screening?
Yeah, the tough part is there other screening available? One, and then we don't have right now the testing capacity, is the answer to that question. And two, as I mentioned, fever can be a late symptom, or can be not the first symptom. And so temperature screening isn't going to catch everybody. And then, can young kids, let's say 0 to 9, can they transfer this disease? They transfer it, according to a big study that came out of South Korea. They transfer it far less than young adults, from 11 to 19, and far less than adults, but they can't, it's not zero. It seems to be that they can transfer it. The age group from 10 to 19 or 11 to 19, they're pretty proficient at transferring the virus, just as well as adults. And so it could be a mixture of factors. Were they a little bit more, because they're older, they have more breath that is being expelled into, and most of these were household contacts. They have bigger breathing systems, so are they putting out more virus? Or are they just bigger people, so they're putting out more virus? Or is it that the young kids, because we do think that the T cell immunity, the T cells are another type of white blood cell. The younger children have higher percentage of active T cells, and also they could have been infected by those benign coronaviruses that have some sort of relayed or conferred immunity that kind of confers onto this new virus. So thank God our youngest of our kids are, on the whole, doing a lot better. There's still the high risk of multi-inflammatory syndrome of children, which they can get very ill from. It's still on the order of things pretty rare. But to answer your question is that I think it was a good thing that they delayed until at least August 17th so we could get a better picture of where this is going. I think the default answer should be our kids do so much better at learning when they're in school. It's just so hard. I don't have children, but I can imagine keeping them and for even parents to just be home. You know, parents have to go and earn a living and do their thing. So for both those reasons, and also because they learn so much better in person, the default answer should be yes. But with the caveat being, we really have to keep a close eye on what this infection is doing. Washington, D.C. actually just said all of their schools should be remote, are going to be remote learning for this quarter and this semester. But that I think should be a last case scenario. And the Department of Education they're getting really good advice, and they're working through all these hurdles. And I understand the frustration both on the parent perspective and then on the teacher perspective, that like, hey, look, we need adequate stop blocks and we need adequate guidance. And it's not an easy answer, and good people are working on it.
Hey, Doc, you know, I'm gonna, because we're running out of time, I want to ask you 3 questions, and I'll just run them down as it is. As far as symptoms, you know, there's a lot of things that falls into that a la carte menu of symptoms.
Absolutely.
If you were just, again, I'm looking at a layperson, what symptoms would you be watching for that kind of point you into the direction that you may have COVID? That's question number 1. Question number 2. You just touched on the schools. What kind of protective equipment would you suggest would be appropriate for the kids at any age going to school because of this virus? And the last question is, someone wants to know about, they talk about again that bubble, that ohana or that school bubble, for allowing the child to go back to school. What are your thoughts on that? So those are the
Sure. Yeah, I think, so with regards to symptoms, I can rework it. My brain works best as an emergency physician from what are the most severe symptoms. So if you have a chest pain, shortness of breath, COVID can cause that. And those are the severe symptoms that you need to get help with immediately. From there on, you've got fever, cough, nausea, a little bit of vomiting, some diarrhea, and lack of smell or a poor sensitivity to smell would be another ones. And then headache, fatigue, and body aches would be other ones as well. And so it's really, like you said, a la carte. We don't have flu transferring right now. So if you're definitely having flu-like symptoms, it's COVID. I think on a positive note, because we're wearing so many masks and we are physical distancing, it's peak flu season in South America and in Australia right now, and they're not seeing flu. And really it's because flu doesn't transmit as well as this virus. And so the mask is bringing that R0 below 1. And so they're not really seeing flu right now. Doesn't mean that you shouldn't be getting your flu vaccination, which is a whole big other story. We could talk vaccinations at another date. So that's the answer to that question. What was the second one? The second one was
the PPE, or what would you suggest would be appropriate? And I guess this also address the fact that, you know, some parents are still kind of on the worried side, you know, how to best protect their child if they have to go back into the classroom.
Absolutely. Yeah, so mask number 1, absolutely. A mask that fits well, that doesn't keep kind of dropping down below the face, that they don't have to keep readjusting. Washing hands or hand sanitizer, I hope the schools are going to have an adequate amount of that, but you can never have too little. And then what ties into that is the third question is the pods, is that, you know, a lot of private schools and colleges have had a hybrid learning where kids only go to school on certain days. And so that gives enough time for them to clear and sanitize the schools until when the next pod of kids comes. And so if an outbreak does happen, that say you're only in one classroom of kids, those 15 kids go to class together all day, that they're not mixing around with other kids. And so the less mixing you have, the less populations are going to be mixing together, and the less risk that you're going to have of people actually coughing or unknowingly spreading the virus to each other. So that's a definite plus. Masks, hand sanitizer, and then physical distancing. And if we can have as much class outdoors as possible, that would definitely help.
Okay.
Yeah.
All right. Thank you.
All right, Doc, we went a little over time. Apologize, but thank you so
It's okay.
much. Is there, if you had to, I think I heard you say this maybe 3 or 4 times, but what would you say to the viewers right now that we can each do individually to help get us through this thing?
Yeah, I'm gonna actually share my screen one more time. I forgot I had one last slide, and it was from my time on working with the Polynesian Voyaging Society. I was on Hikianalia, Hokulea sister canoe, and I know I don't look like I'm from here, especially my name. My name is Darragh O'Carroll. It's Irish, but I grew up here, grew up paddling, and was fortunate enough and honored to be on Hikianalia as one of the medical officers traveling from San Diego back to here. And one of the Olelo No'eaus they taught me was he va'a he moku, he moku he va'a. That's a canoe is an island is a canoe. And what that means is that everybody has a role on the va'a, and not too big, not too small. Every role is vitally important, because if one rope is untied, that could be the difference between a huli or not. And so I took this photo on day 3 of our 19-day voyage, just right, couple hundred miles outside of San Diego. And this was November, so the northern wind was just biting. And you can see here, you've got Kaniela, one of the co-captains, holding down. This is actually one of our cooks, our stoves. You've got Lei here, who's cooking some rice. You've got David Komine helping to hold the rope here, and this hoy is, this is some hard wood that's got no hydraulics on it, and it's steering a 15-ton canoe, perhaps a lot heavier with all of us and all of our water and crew on it. And then you've got Moku here, is probably the strongest man on the canoe, but steering here, no easy task. And then you've got perhaps the most important important person on the boat, Uncle Gary, the chef, bringing up this delicious chili. And so everybody here, what I like about this photo is that everybody here has a role, and we all have a role in this virus. And even there's people behind Uncle Gary here, there's Star making sure we were rocking and rolling and making sure that, Uncle Gary doesn't drop the chili, because that's the last thing we wanted, because we're all hungry, So if I could convey anything, it's that, look, we all have a part to play, and no part is too big or too small. And we can all do your part to combating this virus. Wear your mask, physically distance, and wash your hands, and just do what's right for your ohana and your community.
Wow. Awesome.
He va'a he moku he va'a. That's a t-shirt, man, right there. That's a t-shirt. What do you think, Charles?
I would love to have a t-shirt, but my size, probably it will be on the front and back, one complete line.
Yeah.
All righty. Well, Doc, let me see. How can we? Can you unshare?
Oh yeah. Sorry.
No, that's all right. I like the picture, man. That's a nice picture. 19-day voyage. That you got to work together for 19 days. And I'm hoping that as we get through this, and the closer we get to the other side of this, this all the communities throughout the state can work together and really respect each other. And that's one of the things that we try to promote on this show. We had the mayor last night, and we had a really good show last night. And he was very open and honest, and he was definitely concerned. And I think many of us are pretty much begging the community to follow the rules and follow the guidelines that has been set forth, so we can get through this with as very little injury or death as possible. So anyway, Charles.
Yeah. So first of all, I'd like to extend my deepest gratitude to you, Doc. Again, thank you for reaching out to us. It's always a pleasure having you on. Your second time, so we consider you seasoned now, since you've been on twice.
Thank you.
But we really appreciate the information, and thank you for showing us all those slides. To our viewers out there, again, Mel and I, we try to get the best possible, and we try to have the information ready for you. And you folks can decide. You want to take that information, fine. You don't, and we move on. But nevertheless, we always try to bring the best onto the show so you can make an educated decision on your own. Okay, so I just want everybody to remember that. And to all of our faithful viewers, I know sometimes we have dialogues. I'm watching it go back and forth. Just remember one thing: we're all striving for the common goal, and that is to beat this damn thing so we can go back to normalcy, how it was before, or get pretty damn close to it. But as long as we take chances, and you know, I'm not directing this at you folks, but if you know somebody, talk to them and let them know. The more they goof off with this thing, and the more we get high numbers come in, damn it, guess what? We're gonna be in the same damn position. We ain't going anywhere. So you guys gotta, you know, help us pull the load too. We gotta just make it known to everybody. If we just pull the load, like the doctor showed that one clip, everybody working together in a canoe. If everybody just pull the load, we will get through this. Thank you, Mel.
Thank you, sir. Again, thank you, Doc. I'm not sure if you're following this on Facebook, but if you're not, go check it out. We got some really nice positive comments out there. People very appreciative of your information. So I just want you to know that. As far as Charlie and I, we definitely appreciate you coming back. We will have you come back. I know people are asking for you to come back and talk vaccines, and we'd love to have you back to have a whole hour on just that. We had Dr. Jerome Kim from the International Vaccine Institute in South Korea.
Wow.
He spent an hour with us. Yeah, it was powerful. And we'd love to have your perspective as well. So take care, Doc. Keep up the good work. Stay safe.
Thank you, guys.
Thank you. God bless you
Aloha,
guys. We
guys.
love you. See you guys on Monday night. No more show tomorrow night. Sunday. We'll see you guys on Monday. Aloha.